The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. This is Erin with Fight CRC. We're super excited today for our Research Advocacy Training and Support Learning Lab. Today, we have Dr. Van Blarigan from the University of California, San Francisco, here to share a little bit about her research at the university. So just a reminder to everybody who's on the call, on the right-hand side of your screen, there's a little section where you can type in your questions. Go ahead and do that. I'll kind of monitor throughout the webinar, and if any questions come up real time and there's a pause, we can maybe ask them real time. Otherwise, we'll hold them all for the end. You can also, I believe there's an option to raise your hand. So I'll also be watching for that as well. As usual, we're going to record the session this afternoon, and I will send out an email link to the recording for everyone to watch afterwards. So Dr. Van Blarigan, thank you so much for joining us today, and I'll let you go ahead and take it from here.
Great. Well, thank you for having me. I'm really excited to talk to you a little bit about our work. And so I'm an assistant professor at the University of California, San Francisco in epidemiology and biostatistics. My training was at the Harvard School of Public Health in epidemiology and nutrition. And I'm a member at UCSF. I'm a member of the gastrointestinal oncology program. And my research is dedicated to studying the impact of lifestyle factors, mostly diet and exercise, on survival and quality of life among cancer patients. So we can go to the next slide. And so I'm sure these statistics are familiar to all of you, but I like to include it at the start of my presentations to really drive home how many people are affected by colorectal cancer and the importance of improving survivorship care. So we can go ahead to the next slide. It's a little slow. Let's see. Well, so this does it show? So Sharon, it should show a list. I think it's loading maybe slowly.
I think it is slowly. Yeah, sorry about that.
Yeah, there's no animation. So just, okay, well, it'll come up. But basically, when it loads, the slide shows you risk factors for colorectal cancer diagnosis. And we start with this as, and I'm going to make the point that there's been a lot more research on risk factors for being diagnosed with colorectal cancer than what happens afterwards. And so basically, the higher risk factors for incidence include red and processed meats, alcohol intake, abdominal and body fatness, smoking, and diets high in sugar is a kind of limited evidence. And then for lower risk is screening and polyp removal, physical activity, aspirin, and diets high in fiber, calcium, and vitamin D. But do you know what's going on with the slides? Oh, there we go. There's some part of it anyways.
There it is.
There's no animation, so I'm there. Okay. And so, like I said, these are risk factors for being diagnosed. And of course, it's only observational data, and they're risk factors. Doesn't mean if you do these things or don't do these things, it's a one-to-one relationship. Obviously, you can doing all the lower risk things and none of the higher and still be diagnosed due to other maybe unknown things. And so we can go to the next slide, which is really, but kind of what my research is what about after you've been diagnosed? And so if you go ahead to the next, we really need to build the evidence on diet and lifestyle after diagnosis, because just because something is associated with being diagnosed doesn't necessarily mean it's associated with recurrence or mortality. There's a lot of things that are different after treatment, and with the spread of the disease versus its initiation, we think that a lot of lifestyle factors could be different. And so this graph shows you, it's a search of articles in PubMed, which is kind of the NIH's database of peer-reviewed literature. And it's making the point that basically we have a lot of literature on diet and being cancer incidence, which is new diagnoses of cancer, but very few on diet and cancer progression or cancer mortality. So there's this big gap in our knowledge. And what I'm going to focus on today is kind of what we know so far, and the work we're doing. So you can go ahead to the next slide. And so at UCSF, we have kind of a unique group focused on gastrointestinal oncology survivorship. And it's actually a very multidisciplinary team with oncologists, a wide range of actually different types of physicians who are involved with different specialty areas, nurses and nurse practitioners, myself as an epidemiologist, and then we have dietitians and psychologists and physical therapists. And this talk is also going to talk about kind of our twofold of research. And one is in the prospective cohort studies, so it's observational work and trying to identify lifestyle factors that may be associated with clinical outcomes being recurrence or survival and quality of life. And so these are studies in which patients fill out, usually it's self-reported, like diet and exercise questionnaires, and then they're followed over time to see kind of how they do. And so we do periodic every 6 months. They fill out more questionnaires on their quality of life and different issues, including fertility and sleep quality. And so these are kind of ongoing studies. And I'm going to talk a little bit about some of the data from some of the older studies that were started by my mentors. And so we now have kind of mature data on survival from those cohorts. And then the second part of our research is actually trying to develop primarily digital health tools that will help patients adopt and maintain healthy lifestyle behaviors to lower their risk of recurrence. And so at the end, kind of towards the end of this talk, I'll talk about one of the open studies we have focused on diet, and then one of the studies that we just recently got funded it's a physical activity intervention as well. And so actually, and to learn more about all of this, you can go to our website, which is listed here, and it also has some of the news and new things that we're working on. So you can go ahead to the next slide. And so for the next series of slides, I was going to go through the, kind of one slide per risk factor of what we know now on different factors for after diagnosis and colorectal cancer recurrence and survival. So go ahead to the next. Let's see, so this is, here, it's loading faster, that's good. And so this is, again, now focusing on after diagnosis and risk factors. And you'll notice that some of them are the same, but some of them are different. And so for higher risk, there's been literature now suggesting that a Western dietary pattern, which is primarily characterized by high dairy and refined grains, and a little bit of red meat, but it's really the dairy and grains are the strongest factors. Refined carbohydrates and a high glycemic load, and then sugar sweetened beverages being things that might increase risk of recurrence. And then lower risk is physical activity, aspirin. There's been one paper now on coffee, which I'm going to talk a little bit about, and some new research that I've presented. It's at the ASCO conferences this year, and that are now out for peer review but not yet published, are on long-chain omega-3 fatty acids and dark meat fish and adherence to the American Cancer Society guidelines. And then I'm going to talk a little bit about vitamin D at the end. So we can go ahead and jump in. And I should have said as well, and I think Sharon did say this, but feel free to interrupt, send in questions. We can stop at any time to clarify something if it's unclear. It's a small enough group, we can make this more informal. And so this first slide is the paper that kind of a landmark paper that came out looking at a Western dietary pattern after you've been diagnosed with colon cancer in relation to disease-free survival. And so the graph on the horizontal axis is showing you the quintiles of the Western diet score. So that people in the Q5 have kind of a very Western pattern diet, so to speak, and those in Q1 have a low score on this Western dietary pattern. And so you can see the list. Those are the foods that rank highly with the pattern, primarily dairy and refined grains. And you can see that those patients who had this dietary pattern after diagnosis, it was measured during chemotherapy as well as 6 months after they'd completed chemotherapy. And then they were followed over time. You can see that they had a more than threefold increased risk of recurrence or death compared to those with a low Western dietary pattern score. And they do, in these types of analyses, they're adjusted for lots of things, all clinical prognostic factors, age and sex and BMI. And so it remains statistically significant. So you can go to the next slide. And to follow up on that paper is kind of, so, refined grains and sweets and desserts were highly ranked in the Western Dietary Pattern Load or Dietary Pattern Score. And so the next thing is, this is actually in the same group of patients, and they looked at more in depth on the glycemic load and sugar sweetened beverages. And so glycemic load is a measure of both the quantity and quality of carbohydrates in the diet. And so, for example, quality is basically how quick, it's like a glycemic index, really. And so that's, you know, basically how quickly your blood sugar response after you eat the food. And quantity is just how much you ate of it. And so if you have a very high carbohydrate diet with like a lot of refined grains and added sugars, then you would have very high glycemic load. Versus if you eat mostly like whole grains and maybe in low to moderate amounts, then you would have a low glycemic load. And so they observed that patients with a higher glycemic load after diagnosis had an increased risk of, again, recurrence or death. And similarly, when specifically sugar sweetened beverages are often studied as kind of an example of a food that is, or drink that is really has a very big effect on your glucose and insulin levels, but no nutritive value, and has been associated with other health outcomes. And so when looking specifically at sugar sweetened beverage intake, a higher intake of 2 or more per day was associated with an increased risk of disease recurrence or death as well, compared to those who had less than 2 per month. So we can go ahead to the next slide. And so then now we're going to talk about some of the positive things and things that have been associated with lower risk of recurrence. And physical activity is clearly the number one. There's now been, this is only an example from one study, but there's now been many, many studies in different populations looking at physical activity after diagnosis and colorectal cancer survival. And so in this study, I find it particularly interesting because they were one of the few that could look at change in physical activity levels from before to after diagnosis. And they found, this was done in women, although I think from what we know now, there's no really reason to think that it would be different in men. Those patients who actually had an increased physical activity after they'd been diagnosed compared to what they were doing before had about a 50% lower risk of death from both colorectal cancer specific mortality as well as overall. And so it was interesting because it was actually independent of what they were doing before diagnosis. So if you were inactive before and you increased your amount of physical activity, you could have a big impact, or at least this suggests you could have a big impact on your risk of mortality. And then we can go ahead. And so aspirin, again, there's been many, many studies on aspirin as well. And they all suggest, or at least for the most part, suggest a beneficial effect on survival. There are some caveats because aspirin, physical activity, there really aren't any downsides. As sometimes, there's a lot of benefit and very little risk. With aspirin, there is some risk in terms of there's increases GI bleeding. And the studies while there's been 16 studies, they all looked at aspirin and survival, but these were observational studies and they weren't really measuring, potential adverse effects or bad things that might happen if you had aspirin for a lot of people, which you would need randomized control trials to measure. And so while there's this kind of promising data, right now there are active ongoing randomized control trials to determine if aspirin should be recommended. So at the moment, it's not necessarily something that you want to just go out and do without talking to a doctor, but it is promising. We can go to the next slide. And so then coffee is one of this is kind of an interesting study. I believe there's only been one study in colorectal cancer. And so of course we would like to see more and replication. You can see this just came out in 2015, but those patients who were reported consuming, the benefit was observed at 2 or more cups per day. So those both 2 to 3 cups and 4 or more cups per day categories had a significant reduced risk of disease-free survival, which is both recurrence and death in colon cancer patients. And again, this is after diagnosis. And so, like I said, I'm going to talk a little bit. I have a slide on mechanism that kind of ties all these things together. But coffee is actually interesting. There's been a couple papers now in prostate cancer that have also shown a beneficial effect after diagnosis for coffee intake. And there's now been a bit of other literature from other diseases, including Parkinson's disease and diabetes. So it's possible, and we definitely need more research in this area, but kind of an interesting one. We can go to the next. And so then this is new data, which I presented just this past in January at the ASCO GI Cancer Symposium. It's actually out for peer review now, so should be published soon. But we looked at marine, so long chain omega-3 fatty acids. So these are polyunsaturated fats that are pretty much primarily found only in dark meat and fatty fish, or they're also called cold water fish. And they are essential fats, and we can synthesize them in the body, but it's very inefficient. And so the best way to get them is by eating these types of fish. And so we looked in a population of about 1,000 colon cancer patients at their intake of these fatty acids after diagnosis. And we saw that those patients in the highest quartile, so I'm now talking about the graph on the left, so their median intake was about 400 milligrams a day. And the AHA has a recommendation of trying to get at least for the 500, although the US dietary guidelines are around 250. And for reference, a serving of like salmon has at least 300 for even a small portion of like a 2-ounce serving of like canned salmon has a portion, I think, around 300 to 400. So just that one serving will get you there. And so patients with that highest intake level had about a 28% lower risk of recurrence or death. And so then we looked at the main sources of these fatty acids. We looked at dark fish intake as well, and patients eating dark fish, which includes things like salmon, mackerel, sardines, and herring, had about a 30% lower risk of recurrence and death if they were consuming them about once per week or more. And so one thing to note actually about this, and so kind of one of the things we wanted to look at then would be fish oil. But this population that we were using, because you have to follow people for quite some time to get the survival outcomes and things, this was a cohort that was started back around 2000. And at that time, almost none of the patients were taking fish oil. So the fish, the omega-3 polyunsaturated fat intake that you see in the left graph is all from dietary sources, so primarily fish. Like I said, almost none of the patients were taking fish oil at that time, so we weren't able to examine it. That is something that we're very interested in doing, as at least based on this data, you might hypothesize that fish oil would be beneficial as well. But we weren't able to actually look that specific question in this study.
Dr. Van Blarigan, we do have a question. Is now okay?
Of course. Yeah. Is there a way for me to see it? I don't know.
I'm trying to unmute Kathy. Kathy, are you unmuted here? There you are.
I think so. Can you hear me?
I can, yes.
Okay. My question is, does it matter if the fish is farmed or wild caught?
That is a great question. And so in our study, we weren't able to examine that. It wasn't asked on the questionnaire whether it was, where the source of the fish. And I believe, so it would be a good thing, and I can actually look that up for you and get back to you, whether the omega-3 levels differ. My guess is they don't differ substantially. So to the extent that we hypothesize that the benefit is through your omega-3 intake, it wouldn't matter. There may be other reasons, there are other reasons people choose farmed versus wild caught, largely environmental reasons and like that. But I believe for this purpose, my guess would be that no, it wouldn't matter.
Okay, thank you.
Okay, so we can go ahead. And then, so we recently looked, and with everything I've talked about so far, there are, bits and pieces coming out about diet and exercise and potential role. And so the American Cancer Society actually put out nutrition and physical activity guidelines for cancer survivors. And they first developed these actually back in 2001. And then they've been updated in 2003, 2006, and 2012. And so the guidelines are here on the screen, and they're to achieve and maintain a healthy body weight. And they suggests that the optimal level is a body mass index of 18.5 to less than 25. And that's pretty consistent with kind of all major organizations, including the World Health Organization and others, have kind of identified this range. Although we'll talk a little bit more about that. And then to engage in regular physical activity. And here, so the US physical activity guidelines are 150 minutes a week. And ideally spread out, so you might say 30 minutes a day, 5 days a week. The ACS gave the highest score to those even kind of taking it a step further and saying an hour a day, 5 days a week, it would be ideal. And this is moderate physical activity. So a nice brisk walk, it would be a good example. And then they say to achieve a dietary pattern high in vegetables, fruits, and whole grains. And so this is 5 servings a day of a wide variety of fruits and vegetables, and then choosing whole grains over refined grains and limiting red and processed meats are kind of the details of that recommendation. And so then we developed a score. So patients who were meeting all of those recommendations get the highest score of 5 to 6. So you can see that on the bottom axis. And then if you were not meeting those guidelines, you get a low score of 0 to 1. And we had very few patients who had a score of 0 or a score of 6, which is why those extremes are combined. And so you can see that patients who followed the recommendations after diagnosis had a 42% lower risk of death from all causes compared to those who were not meeting the recommendations. And again, so this is data that was presented at the American Society of Clinical Oncology annual meeting this past June in Chicago. And so it has not been peer reviewed yet, but will be soon. So you can go ahead to the next slide. And so then one of the interesting things is that we then, a common question we get and one that we had ourselves was, does every factor matter the same? And actually all the factors were, when you look at the main 3 of body weight, physical activity, and diet, all 3 were independently associated with survival. But there were a little bit of kind of like caveats or finesse, I guess, on it, in that we saw that patients, the optimal BMI that the ACS guidelines set is kind of that healthy weight of 18.5 to 24.9. But we actually saw that patients, the colon cancer patients in our study who had a little bit higher BMI, so not obese, but in the like kind of heavier normal weight to overweight category, actually had the lowest risk of death. And this has actually been seen in a lot of other studies as well. I think there's some concern. No one really knows if it's causal, so to speak, where the higher weight is actually protective itself, or if it might reflect some bias where sometimes people lose weight when their disease has recurred, or they're undergoing have a lot of high disease burden. So it can kind of look like low weight is actually harmful when it's just it's an indicator of the disease being more aggressive. And so so that's one factor about body weight. It's a little bit complicated. And then for physical activity, although the ACS guidelines gave the highest points to people engaging in an hour a day, 5 days a week, most of the benefits, at least in our study population, were achieved with 30 minutes per day, 5 days a week. And so there was a slight reduction when people increased it even further, but really kind of the largest benefit was achieved going from less than 30 minutes a day to getting 30 minutes or more. And then lastly, for the dietary factors, the important things were really getting that 5 servings a day of fruits and vegetables and choosing whole grains over refined grains if they're, grains are consumed at all to make them whole. And so those were kind of the additional details. And then one additional factor is alcohol, which has both positive and negative health effects, as I'm sure we all know. And for cancer, it's mostly been actually kind of bad or neutral. Although recently, actually, there was a study in 2014 that suggested, and I've only really seen this in one study so far, but that colorectal cancer patients who consumed low to moderate amounts, which is defined as up to 2 per day for men and 1 per day for women, actually had either the same or actually possibly longer survival than abstainers who didn't drink at all or heavy drinkers. I did want to mention that alcohol does increase risk of breast cancer and head and neck cancer. So of course it does have potential negatives, but there is some, if you don't have a high risk of those cancers, And potentially cardiovascular disease is a different concern, which alcohol has beneficial effects on. It seems that, or at least we considered that maybe this low to moderate intake should be included in the recommendations. And so in the next slide, you'll see we added it in to the ACS guidelines score. And so when we did this, the ACS guidelines score actually became much more strongly associated with overall survival, recurrence-free survival, and disease-free survival in colon cancer. And so basically what happened was that by giving the heavy drinkers a low score on that point, it separated people out even more. And so those people with a 6 to 8 on these graphs that you see are people meeting all of the healthy recommendations, including, you know, having a healthy body weight, engaging in physical activity, and eating a diet rich in vegetables, fruits, and whole grains. And then they either abstain from alcohol or they consume low to moderate amounts, being that definition I had on the last slide. And so that was kind of the, you know, the ideal and the lowest risk. And so you can see that those patients had a 50% lower risk of death in our follow-up period, and a 36% lower risk of disease recurrence. And so all these patients in this study, it's about 1,000 patients, and they were followed for a median of 7 years. The total follow-up was up to 9 years after being diagnosed with their colon cancer. Go to the next. And so I wanted to include vitamin D as it's kind of an emerging factor. There have been observational studies that suggest higher levels of vitamin D in the blood, which is this 25-hydroxy vitamin D, is associated with progression-free and overall survival. And then just this year in June at the ASCO annual meeting, there was a big presentation on the Sunshine trial. And so this is a small trial with 139 patients, but it had very promising results where patients were randomized to either kind of high-dose vitamin D or the standard RDA recommendation of 400 IU per day. And those patients who received the high-dose vitamin D actually had longer progression-free survival compared to the low-dose vitamin D. So this is, I mean, a randomized control trial is the kind of, as I think this audience knows, you know, the gold standard study design. And so it is definitely very intriguing. And that study will be collecting data on overall survival, and they're also going to be analyzing the blood levels. So we would kind of have some information about where we want patients to best be. So the current recommendation really is to talk to your doctor about measuring your vitamin D level in your blood, and then you can go from there to decide if you might want to consider taking supplements or not. And then we can go to that slide. And so I wanted to try to put things together a little bit. Of course, this is a simplified overview, and the caveat is out there that there's likely other factors involved, but really with lifestyle, it comes down to kind of these 3 main pathways of inflammation, insulin sensitivity and hyperinsulinemia, and antioxidant activity. And so for the most part, especially, so the omega-3s are really through inflammation. You know, a big thing with physical activity is insulin sensitivity. It's the same actually with coffee, has beneficial effects on insulin and glucose metabolism. And so that's kind of where a lot of the mechanistic research is focused, is on these pathways. And there is a lot of preclinical studies kind of supporting rationale that these factors do indeed matter. And so actually, so we can go ahead to the next slide. And so I just have a summary slide that kind of tries to put it all together. The main recommendation being be physically active, you know, at least 30 minutes a day, 5 days per week, eating a diet rich in vegetables, fruits, whole grains, and fatty fish. And so specifically, it's 5 servings a day of vegetables and fruits, choosing whole grains over refined grains, probably ideally limiting or avoiding refined grains altogether, or at least seeing them as a treat. Having at least 1 serving per week of dark meat or cold water fatty fish. Those are all kind of synonyms for fish high in omega-3s. Avoiding sugar sweetened beverages. And then, you know, if you drink coffee, to continue to enjoy it. Wouldn't necessarily recommend that people start drinking coffee just for this purpose. Of course, coffee has some downsides, and some people have some adverse effects, and it can affect sleep, which would not be a good thing. So it's kind of a personal choice. And then talking to your doctor about aspirin and vitamin D, as any type of supplementation or medication should always be made as a decision with your physician, and not something you just pick up on your own. And so we can actually, so the next set of slides is about our active studies. So maybe we should stop here and see if there's any more questions.
Oh, thank you. Thanks, Dr.
Yeah.
Van Blarigan. So we have a question from Julie Krause. Julie, I'm going to unmute you. You should be unmuted.
I'm on my computer. I don't know if you can hear me.
Yep.
I can, yes.
Okay. So I was just curious about juicing versus ingestion of 5 servings of fruits and vegetables a day. I mean, I could see that, not eating it, you're not getting the roughage and the other things to add to the stool and constipation and some of the other issues that tend to go along with people who have colorectal cancer or who are being treated or taking medication for pain for colorectal cancer. So I didn't know, sometimes with people who are going through that, it's easier to drink it rather than eat it, but I'm sure there's a nutritional trade-off, or I'm asking, I guess.
Yes, well, it's a great question. It's actually a common question that we hear, and you are correct that there is a nutritional trade-off. So generally, our advice would be that juices, they are not a substitute, and because probably a lot of the benefit comes actually with the fiber and other kind of materials that are removed when you juice the vegetables and fruits. The other concern with juices are that they can be metabolized actually really similarly to sugar-sweetened beverages once you remove, the fiber. And so they might have kind of an adverse effect on your insulin and glucose levels, which we want to avoid. And so generally our advice is to avoid consumption of juice, even if it's, 100% vegetable or fruit juice. A smoothie, which has like the whole fruit or vegetable put in and then blended up, would be okay. Like that would be an appropriate thing. But generally we want people to try and eat the whole thing. And so I know that definitely it can be a struggle for a lot of patients in terms of figuring out what works for them, and kind of have to like balance it out. So maybe, as you recover and work through different things, maybe you have to do a compromise and maybe do some of it as juice, in which case certainly if you're going to have juice, I would always pair it with some protein and fat to at least help slow metabolism best you can. But yeah, our general advice is to at least try to work towards finding vegetables and fruits that you can tolerate and getting that 5 servings a day. The other thing to mention actually is that a serving is smaller than most people think. So a serving is usually half a cup, which is maybe, in a woman, maybe a palm full, but if you actually measure things out, it's pretty modest compared to what most people end up eating. So it's a very doable amount.
Thank you.
Yeah, of course.
It looks like I think we have a question from Winora. I'm not sure. Winora, I'm gonna unmute you. Let us know if you have a question.
Not exactly. I'm just listening.
Oh, okay. All right. Sometimes I get signs through the computer. So it looks like that's it for now. So I'll go ahead and move to the next slide.
Great. And so then for these next slides, I'm going to be talking again about our open study. Well, one open study, and then next is an upcoming study. So you can go to the next slide. And so this first study is called Succeed. And so it's survivor choices for eating and drinking. And again, our goal is really to develop digital health tools, so web-based tools to help patients adopt and maintain the recommendations you really saw in the last slide. And so at this stage, we're really just focusing on developing these tools. So like testing them out, getting a lot of patient feedback and trying to tweak and improve and get better. And so that, ideally once we have something that patients really like and find useful and it does help them improve their diet, long term, we would plan a big study that might look at biological and quality of life and clinical endpoints, including recurrence. But first we need a tool that's, useful and acceptable. And so that's the goal of this study. And so patients who are eligible, and this is actually open throughout the United States, it's entirely remote. And so it's open to patients, anyone who's been diagnosed with colon or rectal cancer, who's not actively undergoing chemotherapy and able to speak and read English, and then having access to a mobile phone and able to navigate websites. And you'll see a little bit, I'm going to talk a little bit more about what we're doing and why that's important. So you can go to the next slide. And so this is kind of an overview, and so we call this a schema. And if you start at the top and work your way down, it's the flow of what happens in the study. And so at first, patients are asked to keep a diet record. And so it's 4 days of using an online system developed by the National Cancer Institute to measure patients' diet. And so it's, you go online, you can use it on your phone or on your computer, and you record everything you eat and drink for 4 days. It's a pretty user-friendly system. And then once you've done that, you go to your local LabCorp, which is there's locations throughout the US, and they measure height and waist circumference and do a blood draw, and then do, I think, blood pressure. And then we have a set of surveys that are emailed to you. And then once kind of, so that slew of baseline assessments are done, patients would get randomized to either receive, and it's called a waitlist control. So everyone will get access to the site. It's just at different times. And so the first group gets access to the intervention right away for 12 weeks, and the other group gets print materials, and then we repeat the assessments, and then they switch. And so then the control group, or the waitlist group, gets access to the intervention after the 12 weeks for an additional 12 weeks. And then at 24 weeks, everybody repeats the diet records and surveys, but we do not repeat the blood or measurements. Those are just at 0 and 12 weeks. And so that's kind of the flow of how this works. And then if you go to the next slide, so this is a little bit more about what happens during the intervention. And so there's an orientation session with our clinical research coordinator, which walks people through setting up their account on the website, which is a secure website. You have a username and login, you set up your profile, you customize it to your own goals and things you want to work on. And then you get a personalized diet report, which helps you during the orientation to set your goals. You can see there's these different features on the site that include, like I said, goal setting as well as diet tracking. It has all of our recommendations and recipes and some meal planning tips, and then a frequently asked questions section. And it's really designed to be used on a phone, so it's a responsive site that works well on a phone for 5 to 10 minutes a day to track foods and beverages. But it can also be used, less often. Sometimes people would rather write things down and then go in and put it in on their computer at the end of the day, or whatever they choose to do. There's also daily text messages to help patients, support adopting a healthy diet, and patients can customize when they receive them in terms of morning, afternoon, and evening, and they can also turn them off at any time. And so they're just at that bottom of the screen. That's kind of what part of the website. It's our logo, and then kind of the menu bar. If you want to go ahead to the next slide, it has a little bit of a screenshot, just a section that shows you a little bit of how it looks, and kind of the idea of like how these different tools that are available. There's also a way to easily contact us and send us questions, as well as send questions that we give to the Cancer Center dietitian to help patients kind of achieve our recommendations. And then, let's see. And so just to, like I said, it is openly enrolling, and anyone throughout the US is potentially eligible. And so, of course, you can always email us, and then there's just an online screening survey that's pretty quick that people can take to see if they might be eligible to participate. The main reason so far patients probably aren't eligible is usually because if they are already meeting too many of our recommended dietary pattern or dietary factors, then they might not be eligible, but it's always worth a check. So certainly I would encourage any of you, and then anyone you know, to go ahead and see if you might be eligible to participate. We definitely welcome anyone. And then, so this is our new study. It was just funded to build off of a study that we recently completed. So we're looking at physical activity. And so, of course, both matter, diet and physical activity, but we've been kind of in developing these tools, focusing on kind of one step at a time. So we're just asking patients to focus on digital health tools for one or the other at first, and then our next step would be to combine them. But so for this study, as I talked about earlier in the presentation, colorectal cancer patients who report, so I talked about how higher levels of activity after diagnosis are associated with lower risk of recurrence and death. But on the flip side of that is those patients who decrease their activity, which is most, actually may have an increased risk of recurrence and death. And so similar to that is that most patients, and again, this isn't everyone, lots of people, but at least on average, people tend to engage in less physical activity 6 months after diagnosis compared to before. And so our goal, we really want to help patients at least, maintain their activity as best they can in order to try and lower this risk of recurrence that we've seen. And so our goal is to try and build tools that'll help patients get through, their treatment and that initial phase after treatment, and maintaining as much physical activity as they are able. And so this is using a Fitbit, which many of you may be familiar with. It's the one we use on the wrist, and text messages and other support tools to try and see if that's something that patients would be interested in during their chemotherapy for colorectal cancer. And so, like I said, we hypothesize that if we're able to help patients maintain or even increase their activity during chemotherapy, it might prevent the drop-off that we see in the data and can, improve both symptoms during treatment as well as quality of life and, hopefully increase survival. And so go to the next slide. So that's the focus of this study. It's, again, also a 12-week study and a similar number of patients. And it's a little simpler. It's just the 12 weeks, although, so it's not mentioned on this slide, but everybody gets to keep their Fitbit at the end. The group that is randomized to not receive the intervention is given a Fitbit after they finish their 12-week assessments. And so this is a new study that, like I said, has just been funded. And so we are working on the protocol, and it will be hopefully open this fall. And it is funded by the Osher Center for Integrative Medicine with a complementary their goal is to improve complementary therapies for cancer. And so we're trying to really, focus on physical activity as kind of a potentially ideal, almost adjuvant therapy you could think of for improving tolerance to chemotherapy as well as outcomes afterwards is the goal there. And so I think that brings us to the end. So I just want to thank, just put out that we have a big team that works on this. These are kind of key PI leaders of the team. Of course, we have a lot of staff and patients who are, we could not do this without. And then all of our funding is primarily from the National Cancer Institute and then UCSF organizations. And I did, again, put our website there at the bottom for the survivorship program. And it's a great place to go. It has our contact information and more about both the clinical side as well as the research side of our survivorship clinic. And so I think that brings us to the end, and happy to take any questions that you have.
Thank you so much, Dr. Van Blarigan. We have a question from Kurt Pessman. Kurt, I'm going to unmute you.
Thanks. So I had written in the question, but I was very curious, since we know there's a link between ulcerative colitis and Crohn's disease and inflammation and increased incidence in colorectal cancer. Are there any studies yet showing similar patterns with either gluten sensitivity or celiac disease, because it's also long-term in terms of inflammation? Anything yet?
That's a great question. Not to my knowledge, but that was something I would definitely be interested in looking at. So it's a great question, but yeah, not to my knowledge that there's any studies out there.
Okay, thanks.
Mm-hmm.
I have a question about the programs that UCSF offers in terms of, promoting healthy diet and physical activity. Have any of your programs been implemented in community cancer centers or replicated elsewhere in the country? And if not, what are some of those challenges to getting this research and programming out to a broader audience?
Yeah, so that's also a great question, and the answer is no. But it hasn't yet been, like, so we are in the initial phases. They're pilot studies. They're, so small, and that would definitely be a next step. But I think, at first we have to kind of finish these and see whether we, what type of reviews we get essentially, and whether it's determined that the interventions are feasible and acceptable in this initial population. And then I think we will definitely want to expand. I think even just at UCSF, one of the big limitations, it's not a limitation, but a challenge that we have, which really just comes actually down to funding, but is actually language. And so a big thing is that one of the, right now, all of our, these programs are developed and offered in English. And we have a lot of patients who do not speak English, but they also don't speak just one other language. We have we get everything in small amounts. And so I think one of the challenges to broader implementation would be developing kind of culturally sensitive and translated programs into a couple different languages. And then so that's kind of one of the things that we have on our radar and one of the things we want to do. But yeah, so it's something that needs to be done for sure. We just aren't quite there yet.
Great. Thank you. Julie, I'm going to unmute you now. Okay.
Hi again. I just had a question. I know there was a lot of excitement at ASCO this year about tree nuts and colorectal cancer. So I just was interested in your take on that.
Yeah, I should have included it, the results from that. And so yes, there was a lot of excitement, and there was very dramatic benefit seen with patients consuming, I believe it was 2 servings a week, although I would have to double check, of tree nuts specifically. They looked at total nuts, including peanuts, although those are technically a legume. And then when they separated it, really the benefit was the tree nuts. And so I think it is really interesting and definitely has some potential biologic mechanisms. There's been a lot of data actually coming out of cardiovascular disease, diabetes on nuts and their benefit. In fact, there was a big study of cardiovascular disease prevention that is a big randomized trial in Spain that actually showed that consuming like a serving of nuts a day lowered risk of incident cardiovascular disease. Is very dramatic. And so it's similar mechanisms, insulin, inflammation. And so I think that also has a lot of promise and would be one of the things that kind of, if we were going to continue to improve the recommendations of those ACS guidelines, we add in the dark meat fatty fish and we add in some tree nuts, and it certainly has a lot of promise.
Okay, thank you.
Okay, Elaine, I'm going to unmute you now. Elaine, did you have a question? Okay, we can't quite hear you. I'll leave you unmuted in case the volume comes up or something starts working. But we just have a couple more minutes. If anyone has any additional questions, I guess feel free to type them into the question box, and we'll leave it open for just another couple of seconds here. Okay. Well, thank you, Dr. Van Blarigan, for a great presentation. The research you're doing is super interesting and exciting, and we look forward to seeing how it all pans out and reading more about it in the future. So thank you so much.
Of course. And if anyone has follow-up questions, you can always email me. I believe the email's on the first slide. Perfect.
And as a reminder, I will be sending the link to the YouTube recording in just a couple of hours. So if you guys want to rewatch it or share it, you're more than welcome to. It looks like we do have one question that came through. Do you have time for one more?
Yeah.
Okay. So this is from Kathy. Kathy, I'm unmuting you.
Okay. Reviewing the Succeed diet, the study that's open, I saw that one of the parameters was that you cannot be on chemotherapy. Why is that?
Yeah, so that's so for that study we are focusing on after chemotherapy because a lot of patients, or at least we were concerned that a lot of patients may you know, kind of change their diet or struggle to meet the recommendations during chemotherapy because of the side effects of treatment. And we didn't want to, we wanted to see kind of how patients would do being able to follow the recommendations, you know, once treatment was removed, not part of the picture. I think a next step though would certainly be to include patients on treatment and try to better understand what dietary factors do change, you know, and what you know, how we can help patients kind of find what they can do. So that's certainly a next step. But at first we were looking at, yeah, post-treatment.
Okay, it's just I've been on chemo for 4 years now, and I understand, you know, the really rigorous chemo. Yes, my my diet did change, but now because I'm on what I call chemo light, I eat just about anything I can, anything I feel like eating. So I'm assuming it would be beneficial to follow
Absolutely.
those. Okay.
Yeah, and so that's actually really, you know, kind of good information for us as well, and whether, you know, whether we should refine our eligibility to say include chemo light as eligible. I should talk to the oncologists on our team and see if we can better, because I mean, from what you've described, you know, we would certainly want to include you in the type of, you know, people like you as well as in the population. So so that's a great point, and I'll follow up on that.
Okay, thank you.
Great. Well, thank you so much, everybody, for tuning in live. And special thank you, Dr. Van Blarigan, for taking the time to share all of your research.
Thank you.
Thanks. Have a great day, everyone.